So we're very fortunate to have Dr. Jamie Ho join us, and she is a graduate of the Illinois College of Optometry in Chicago, and she completed a residency at the New England College of Optometry in Boston, Massachusetts, and she is the director of Ho Vision Group in Nashville, Tennessee, and she's going to be presenting a lecture to us regarding low vision rehabilitation, improving quality of life. Thanks so much, Jamie.
Thank you. Thank you, Lang Vision, for inviting me to present. And so without ado, I'm going to be talking about low vision rehabilitation and how it can improve the quality of life. So I have no financial disclosures. Marianne already had alluded to this. I am a fellow, both of the American Academy of Optometry and also of the College of Optometrists and Vision Development. So Ho Vision Group, for those of you who are not in the Nashville area, we're based in Nashville, Tennessee, and I specialize in low vision and neuro-optometric rehabilitation. So some of my goals for today will be to define low vision and identify different types of visual impairment. We're also going to review elements of a low vision exam and clinical tests to assess functional vision in a low vision patient. And so nothing is going to be really specialized. I'm going to kind of stick to this as I had geared this talk towards primary care optometrists. And also going to give you a brief overview of different low vision tools we have. So what is low vision? So low vision by definition is poor vision that is not correctable by glasses, contact lens surgery, or medicine. I'm going to define it in different types. So we have normal field loss, which can be central, it can be peripheral, it can be little islands. I would also throw in some sensory conflict, which can also be very impairing. Metamorphopsia, which we see a lot of in retinal diseases, and this will also encompass legal blindness. By definition, legal blindness, best corrected visual acuity 2200 or worse, visual acuity of less than 20 degrees. It's either or, so you don't have to have both. So in short, patients can be 20/20 and still visually impaired. So a lot of my RP patients actually are probably 20/40. I have one who's 20/25, but they have like 5 degrees of visual field, so they would be considered legally blind. So who refers to our practice? Just kind of to give you an idea, sense. So we have ophthalmology, optometry. I do get a lot of retina referrals. Vocational rehab, you might have an equivalent. The vocational rehab is a division of the government that is in charge with helping patients regain or maintain employment. So they will supply financial means, if it's tools or if it's therapy programs, they will pay so that patients will not end up on disability. I also do get some referrals from schools, also work with the local School of the Blind. So what type of patients do we see? We see the standard, what people think of low vision: macular degeneration, diabetic retinopathy, glaucoma, optic atrophy, Stargardt's, retinitis pigmentosa, ocular albinism. Those are probably the more common ones. We also see a lot of cortical visual impairment, which could be either congenital or acquired. So acquired brain injury, stroke, brain injury, concussion. So what's in a low vision exam, and how does this differ from a primary care exam? So we're going to look at different elements, and so this is my little roadmap. We're going to talk about history, visual goals, and look at different elements in the visual acuity. I do some binocular vision testing. I'll tell you why. Trial frame refraction, contrast sensitivity, visual field testing. So case history, what I want to know about a patient's ocular condition is, especially for retina, is the patient currently being treated, or is this a stable condition? That's not to say that I will get away from patients who are receiving active injections, but I also like to kind of have an idea of whether or not I expect to change a patient's glasses over time just because they're undergoing treatment. And as you know, the retina tissue might change over time when we're doing that. We also want to review patient expectations. A lot of my patients come in and they say, well, can you not just put more power into a pair of glasses so that I can see? And a lot of times with low vision, we're going to need multiple tools, and glasses might be just one part of the formula. Just like with specialty contact lenses and vision rehabilitation, vision therapy, we really want to set up our patients to succeed. But if they over-expect, if one of the big things I tell my patients is, no, low vision does not make that visual field go away. It does not make the acuity loss go away. And so a lot of times if the primary care doctor kind of sets that expectation, the patient kind of knows a bit better what to expect when they come in to see me. So like I alluded to, glasses alone may not offer a solution. And I still encourage my patients that they need to be followed for their ocular and systemic medical conditions. Dr. Rock just now had listed a whole list of ocular emergencies, and sometimes we still see them, but it's very important that patients get followed. So I always tell my glaucoma patients, you got to go back to your managing doctor. You know, I'll deal with the low vision, and then you have to go back. Retina, same thing. So what are visual goals? This is probably something new to primary care, but I look at goals, and it's not just patients coming in and saying, doc, just make my vision better. I want them to have specific goals. So in my intake sheet, I will give them examples of goals, and hopefully they can list 3 goals that we can work on. I'll give you some examples here: orientation and mobility. So I want to be confident. Sometimes some of my patients with low vision, they feel like their balance is off, or they feel like they can't see well enough to be confident to walk around outside without falling over. Some of the more common ones, I want to read my Bible, I want to watch TV, I want to be able to use my computer for my job. So some of them could be vocation, job specific, some of them could be hobby specific. I had a patient who initially I kept thinking he was saying crosswords. This was when I first moved to Tennessee and I was not accustomed to that lovely Southern accent. It turned out my patient did cross stitching. And sure enough, I told them, okay, next exam, bring in what you need. And lo and behold, he surprised me. He pulled out from a garbage bag a huge, huge panel that was this big, and it was embroidered with really, really beautiful, intricate flowers. And that is a goal, that is a specific visual goal, and it requires a specific work distance for the patient to comfortably do. So we got to measure some of these, this work distance. Driving is another common visual goal, independent living skills, and minimizing sensory conflict, confusion. A lot of my low vision patients will tell me, I feel confused. And this is not necessarily psychological, but yes, low vision can result in a lot of psychological trauma. So do watch out for that. So visual acuity, yes, we can use a standard Snellen chart, which all of you are familiar with. In this picture, this is a fine bloom acuity chart. And so it's got isolated numbers, and generally you stand far away. And we see there's much more contrast on this chart. There's less chart glare for those of you who are on those digital visual acuity charts. And there's a whole lot less crowding. So crowding happens when you have multiple lines and there's lots of things competing for the patient's visual attention. And so you can see the numbers here are there's a lot of white space between the numbers. So why would we want to measure visual acuity with anything except Snellen? So Snellen can understate functional acuity. So for example, I might get a referral and the referral might say, okay, we have acuity of counting fingers. But then if we use a Feinblum chart, we found out the patient actually measures 2400 at some distance. And that means if they can get an acuity, that means they might be a good candidate for magnification, and that this is some level of functional acuity. So just thought I'd bring this up. We also use different types of acuity charts with different levels of cognitive difficulty. Many of our low vision patients are older, and so sometimes there are cognitive deficits that accompany different health conditions they may have. So yes, we have Snellen letters, we can use numbers, we can use the Landolt-C or the Landolt-E. Some of you are familiar with it from the pediatric standpoint. That's the one that has a little circle, so patient points up to you is the opening facing one direction, up, down, left, right. Also can do some symbol matching, which I'm going to show you. That's what symbol matching looks like. This is great if my patient has aphasia. Aphasia means they're not able to communicate with me properly or understand speech. Okay, so some of you may be interested to see why I am doing binocular vision testing for my low vision patients. So this would be a standard amount of testing that I do, definitely not a comprehensive list. So I do a cover test, I do a Word 4 dot, a Maddox rod sometimes, some sort of stereo and near point convergence. And definitely I always look at ocular motor, smooth tracking pursuits, and ability to jump saccades. So why do I look at this? Because strabismus is very common in my low vision population. For anyone who has macular disease, a lot of times we'll see patients with eccentric viewing. And you'll see sometimes those are the patients you get them to take an acuity and they're kind of, you know, angled really funny in your chair and they're shifting their head around because they're trying to look for the acuity chart. So when they're not using foveal fixation and they're using, instead the brain has adapted strategy to use retina next to the fovea because the fovea is damaged, we end up with eccentric viewing. I also look at this as a sensory adaptation period over time. So for patients, can they adapt? Like, you know, how long have they had the eye disease? Because typically if they just notice it, they don't develop eccentric viewing. And one of my big ones is there any prior history of having strabismus? Did they have an eye turn prior to the disease? So my next slide is going to tell you why. Why are we looking at strabismus so much? One of the big things is, does the leading eye or the dominant eye have better vision? And that's really hard to define. So I'm not saying vision meaning just acuity. So if we have an eye that's 2100 and the other eye's 2040, does that mean the brain is going to favor that 2040 eye? I would say it depends. It depends on what else is going on. It depends on contrast. You might have worse contrast in one eye compared to the other. You might have metamorphopsia. Currently, I have a patient who was a professional painter. So he did a lot of realistic paintings. And he's actually undergoing active injections in both eyes. But his poorer eye, or his poor seeing eye, is the one with less metamorphopsia. And since he is an artist, he's hyper aware almost of which eye should be leading. And as I said, this does depend on if they're undergoing active treatment, and this can change over time. The second thing I look at is the patient disoriented? Do they have diplopia? And yes, you can get monocular diplopia sometimes from some of these retina conditions. So I kind of look at this as an adaptation period. And the other time, you know, why strabismus is sometimes patients just unlucky. They have the disease, take out their good leading eye, and they had strabismus before. So all of a sudden I'm left trying to get the patient to appreciate acuity with their amblyopic eye or their strab eye, which makes things a little difficult. So we need to do some rehab work there sometimes. The other things I look at is whether the condition had a sudden onset. We also want to look at comorbidities. So for example, a stroke can result in very confusing different sensory and also oculomotor patterns. So I've had probably 3 or 4 referrals within the last half year where the patient said they couldn't see, and after we ran a field, I ended up referring them for further imaging of their brain. We had one patient actually had a benign tumor. I had another patient who actually had multiple undiagnosed strokes. And then we had a third patient. I think the third patient also had another type of tumor. So we do need to be really careful. We just can't look at low vision and say, okay, they have macular degeneration and that's it. Okay, so I do trial frame refraction. I actually don't use my phoropter a whole lot. And yes, some people might be saying it's a little more time consuming, but I can change the lenses out really quick. And if you practice, you get pretty good at it. So why would we trial frame? This is so much better for our patients who need to eccentrically view the chart. Again, so those are the patients that look at the chart and you tell them, are you looking straight? And they say, yeah, they're kind of tilting their head in all these awkward positions. They won't look straight ahead. So if they're behind a phoropter, they can't do that. This is, trial frame lets us see things in free space. They're not behind a phoropter. So a phoropter blocks out a lot of peripheral space, and that might change how they use their vision. And you can also observe their posture. And because sometimes I might use some prism just to kind of balance out their awkward head posture. Okay, so now we're on to contrast sensitivity. And so the classic would be a PELLI-Robinson chart. And so for those of you who don't remember this from school, these are letters of the same size and they have decreasing contrast. PELLI-Robinson is not the only type of chart. There's the lighthouse chart. I use that in my office. There's a lot of variants right now. So there's definitely a big market for contrast sensitivity testing. And recently, there's also a lot of contrast sensitivity testing for maculars, for supplements. I know MacuHealth also does one too. So what is the faintest triplet in which the 2 letters are correctly identified is the starting point. So it's like visual acuity. So you kind of go down this chart until you can no longer, the patient says, you know, I can't see anything beyond that. And then there's usually some sort of legend, corresponding legend, and then we want to convert this to a log contrast sensitivity score. So 2.0 for contrast sensitivity, that's considered normal. If you're below 1.5, we suggest that it's some sensitivity impairment. If you have contrast under 1, this actually is considered a visual disability. So in my office, we will test left eye, right eye, and then both eyes. So that's a little chart kind of for your reference of all the log contrast sensitivity function. That's what CSF stands for. In children, a little bit lower. Sometimes it depends on their attention. So not many of you might not have a PELLI-Robinson chart lying around. They're a little bit costly because, especially if you have print ones, because it takes a lot to replicate that ink. So here are kind of some shortcut ways, some screeners. Eschenbach does make a continuous text chart. This is good. So we have, this is like 2,400 text. You hold it at 16 inches. And they basically read. The good thing about this chart is you can also kind of get a feel for how impaired the reading is. And so if they kind of lapse right through and they do fine, it's, you know, generally good. And so as you flip the page, the contrast gets worse and worse. And you might be able to see, I don't know if some of you can see it on your screen. So there's a little kind of, it says 25% on this picture here. I also have a pediatric screener. This is HEIDI. And so it's a forced choice. So you hold two of them. And basically, if the child or if my patient who's using this, they're going to look for the face. And so there are different grades of HEIDI. All right. Do you have any questions so far? Oh, I do have a question.
Yeah, we just got one.
Okay, so would you expect, the question is, would you expect contrast sensitivity results to change if checking distance visual acuity versus near visual acuity? That's a great question. Typically, I would expect it to be around the same area. The lighting has to be similar, so that's probably a big one. By habit, most of the time when I do near visual acuity, I turn it on the top spotlight and shine it on the page. Now, if I have a patient who is super glare sensitive, their performance might actually go down and get hindered by that. Same thing with your room illumination. If your room is not symmetrically lit up for whatever reason, and you're using a print chart distance, we got to be very careful with that. But typically, I would expect the distance and near to be within a range of each other. Okay. Did I answer the question? Good. Okay. All right. So another best way, if you aren't into contrast sensitivity and you have a visual field around, this will be the visual field. So as you know, the MD and PSD readings will also kind of give you an idea of their contrast. So what are we looking for when we do visual fields? I'm gonna go over all the different types of fields I use in my office. So this is a threshold field. Most of you are familiar with this. You know, most of us use this for glaucoma and to look at other eye diseases. I wanna look at central versus peripheral field loss. Yes, someone raised a hand here. Albert Nguyen. Their question?
I don't see any here, but let's see.
Can you type it?
Yeah, please put it in the Q&A and I'll make sure to let her know.
No? Okay. All right, I'm going to be watching for it, so feel free. Ask me questions along the way. Like we have plenty of time. Okay. So for threshold fields, we can use this as tracking sensitivity as a marker of disease progression, like in glaucoma. And as I mentioned before, we really want to rule out concurrent conditions like stroke. And yeah, I have quite a few patients who have both low vision and also have had a stroke. Central and peripheral field loss. Okay, so we're going to talk a little bit about this. So this next, let's see. This is a binocular ESTERMAN field. Some of you, if you certify for driving, this is typically the field that is accepted. So it does 120 test points, and it's a binocular field. And how it differs from a threshold field. So the threshold field, like in glaucoma testing, you know, some of the lights are really bright and some of them are a little dim, and it's kind of, you know, we map out sensitivity. So in an ESTERMAN, we actually just really have a big bright light flashing going off. So it is not a threshold, it's just, does the patient see it or do they not? And so for driving, we want at least about 150 degrees at least. And so you can see that's the 80 mark there, and that's the 80 mark here. This is, I have an octopus, and this is actually a kinetic field. So how this differentiates, so we talked about threshold, which is monocular, and threshold grading sensitivity. We talked about binocular Esterman, which is actually with two eyes, and it's not threshold. It's can you see it, can you not? This is a kinetic field, which is similar to binocular Esterman. It's usually a target, and you can, my machine, we can actually adjust how big the target actually is. And I tell my patients it's like a shooting star. So instead of like the last two types of fields we talked about, the light turns on and then it turns off. Instead of that, the light actually travels along a path, and then my patient still stares in the center, and when they see it, they click the button. So it is a moving target. What I use this for is to see how well does one compensate for their field loss. So you can see here on my picture, this patient has a heminopsia. You can see this was their Esterman. You can see it's a little smaller, but they have like a full out hemi field loss. It is pretty dark, you know, near absolute. But in kinetic, it doesn't actually stop right at the midline. You actually see this bleeding over into 20, 30 degrees, which means, and this I think wasn't done with any other aids, no prism, no expansion prisms or anything. So if I have a patient who is starting to develop these small saccadic compensatory eye movements, I will expect this bleeding effect to be present. If I have a patient who is a very poor adapter and they have no awareness of anything in their field loss, it will cut out exactly in half, right at this midline. It looks like literally a piece of pie, and that will kind of match up with, you know, the threshold field loss or the binocular Esterman. This is also really important when I look at driving aspects. So for low vision tools, we're starting the kind of last part. I'm going to classify it into three different categories: light and glare management, magnification, and environment and behavior modifications. So for light and glare management, it's not just about having more light. So I just talked to you about bringing that headlamp over when you're using the near acuity chart, and sometimes that's not a good thing. It's about using light efficiently, and how light is efficient for one low vision patient will probably differ from the next patient. So there's not a standard way. For someone who just has mild low vision, I look at eyewear. So we do want to, we do want to prescribe anti-reflective coating, polarized lenses if they're very light sensitive, they're by the water. So a lighting assessment. Generally, I tell my patients I want a directed light source because we want to reduce the amount of scatter. Scatter is like a torch here. So if you have a torch here lamp in your house, you notice it's just shooting light up towards the ceiling. It's not directed at all. You see on my picture here where we have a directed light source. Where to position the light? Generally, I position the light if my patient has a poor seeing eye and a good seeing eye. We position the light over the shoulder of the good seeing eye, and that kind of cuts down on some of the glare. How do we position reading material? So we use book stands because sometimes the reading material, we want it to be parallel to the magnifier surface so that we cut down the glare that way. And sometimes some of the reading material has, different types of reflectile properties. And yeah, where do we position additional magnification? And visual comfort. So there's intensity of the light. Again, the biggest, brightest light is not the best option. Some of my patients do better with just slightly lit up. And the color temperature. color temperature, if you've ever been to Lowe's or Home Depot, and you go to the lighting section, there is, there's usually a little display, and it's got like 4 little sections. You'll see a really yellow light, like in traditional incandescent, which some of us grew up with. And then you'll see the really blue light, which is the fluorescent lights that we'll see a lot in department stores, and we'll see that in like warehouses and Walmart. And so some patients are really sensitive to fluorescent light. So we gotta be very careful with the type of light as well. Gonna talk about absorptive filters. So why do we use absorptive filters? We use them to improve contrast so that one can separate an object from the background. So here's a huge stash of absorptive filters. We can get pretty much anything in any color. In my office, we can use a standard fit over. You can see it on the picture on the right here. And we can also custom tint eyewear or tint contact lenses. So you can see we had an absorptive filter here on the right, and I asked my lab to match, and you know, those contact lenses turned out pretty good actually. So why do we use tinted contact lens? Sometimes absorptive filters is still not enough. We have patients who are super sensitive to light and glare, and sometimes some patients will be kind of conscious, you know, if you're asking them to wear a filter like this in their day-to-day life, they might not like it. I just saw my little boy today who with low vision. He's not little, he's 15, and he did really well with a red filter. He had rod cone dystrophy, and one of the best things I remember, as he sat in my office a few years ago, he said, "Hey, is there any way I can get this so that my friends don't really know I'm actually wearing it?" So we have to be careful with the teenage population because it is very sensitive. But I also do this. I have a couple of my patients who have low vision, and they are in stage production. So they get subjected to all types of really funky light in all different angles. And so custom contact lenses are generally better for that. But yes, we can also custom tint their eyewear.
I have a question for you.
Yes.
Do you have any success with using any like drops like bromonidine for light sensitivity for patients like that, or?
It really depends on what's causing the light sensitivity. I don't know if I would venture on using bromonidine long term to manage the glare. And you have to remember that most of these patients might not be chronically light sensitive, meaning they just are light sensitive under certain conditions. So I like to have the versatility of a filter or contact lens where I know they have the option of taking it off if they have the choice, which is a little harder to manage if it's pharmaceutical. But cannot say I have much experience using bromonidine.
Thanks, just curious.
No problem. Okay, so why do we want to improve contrast? So a few slides ago, I said one of the visual goals for some of my patients would be improving mobility and orientation. So this is a picture of parking lot, and you can see pretty bleached out. And so this is how some low vision patients see the world. So behind a filter, you can see there's a much better differentiation between the sidewalk and the road. And again, since a lot of our patients are older, I'm very concerned of them falling if they cannot see it. They can also see the cars kind of stick out more. So again, thicker ground is probably another way to describe this. All right. So magnification tools. There's handheld, there's stand magnifiers, telescopes, CCTVs, closed circuit television, and some digital wearables that some of you may not be aware of. So this is, you know, traditional stand magnifier, hand magnifier. couple caveats with traditional magnification. So the greater the magnification, the lesser the field. So it gets to the point sometimes we mag up so much that it fills that work area and we might only see one letter versus an entire word. Not very helpful if we're trying to read, right? So greater magnification, greater distortion. So generally with these traditional magnifiers that you see down there, the periphery, the very edge of the magnifier has some distortion. So only generally the center is clear. And the third, probably catch-22 of greater magnification is more sensitivity to motion. This will be really relevant for when we talk about wearables. And it's important to understand that every device has its limitations. Just like when you're prescribing glasses, you know, the ad, you're progressive, you tell your patient, you know, you have that sweet spot, and you go and show them, you bring the reading material close, does it get blurry? Yes. And then you push it out, it gets clear again, and it gets blurry. These are magnifiers, and this effect is also very important to go over with our patients. So how do we estimate magnification? So Kestenbaum's rule, a long time ago, some of you might have remembered. So let's say 2040 would be sufficient for most tasks. So if my patient has 2200, and again, you know, we measured functional acuity, maybe not necessarily through a Snellen chart. So let's say my patient comes in, has 2200 vision, and we have a goal, we're going to try to get them to a 2040. So you basically just kind of divide the numbers, and we estimate here approximately about 5 times. I would, you know, if I looked at a calculation like this, I'd say, okay, you know, we try the 4, we try the 5, we try the 6. We kind of try all the numbers around it. Remember, the higher power the magnification, the closer the patient has to bring it, and not all patients are comfortable with that. My rule of thumb is generally I try to prescribe the least amount of usable magnification. So here are some examples. This is a bar magnifier on the left here. And then we have this is a stand magnifier / hand magnifier by Eschenbach. And so you can actually pull this handle out and then it becomes a hand magnifier. So, you know, different types of magnification. And yes, right now, all the companies make things of all different sizes. So this entire line I'm just showing you is from Eschenbach, and you can see they have screens, digital magnifiers. This one's a few inches, this one's a little bit bigger, and you know, it keeps getting bigger. So all shapes and sizes. I look at portability. Some of my patients, women especially, they want to find something that fits in their purse. So really, the sky's the limit right now. There's tons of magnifiers out there. Okay, so how does the magnifier develop? And you know, those digital magnifiers kind of share the same thing with CCTV. We have less distortion optics. Remember, I said the periphery tends to get distorted in a traditional magnifier. You can do color inversion. So instead of white on white background, black print, we can inverse it and do black background, white print. And or sometimes we can turn it yellow, we can turn the font green. So color inversion is very helpful for some of my patients. We can do a screen freeze. So this is good for my patients, especially if their hands are not steady and they're trying to hold something. They might just snap a picture of it and then they can zoom it in, zoom it out, use the magnifier function later. Some of these can, for the CCTV, some of them can now integrate with optical character recognition. So it can literally read everything to you and play it back to you in audio form. So that's my traditional CCTV. You can see that over here. And traditionally, you know, this thing is kind of big and bulky. And so portability was definitely an issue. Now we have a newer line of compact CCTVs, which are generally great for my students. So there's so many here, but I'm just kind of giving you an example. This is a MagniLink tab. It runs on a Surface Pro. And you can see this whole stand, you can like collapse it and it becomes the size of a laptop, really. There's magnification, there's OCR. You can toggle between the USB, the tablet. You can have Bluetooth keyboard. It literally operates on Windows. And so there's a lot of versatility in these newer generation CCTVs. All right, and we have spectacle magnifiers. This on the left here, this is clear image 2. This is actually a double fused glass. So remember I talked a lot about distortion optics. So generally the higher mag, the more distortion we get. So this is a double fused glass. It is, I'd say, a little on the heavy side, but the advantage for this, for both of these is, yes, it allows for hands-free operation. So if you have a patient who wants to sit there and they don't mind holding the material really close, this would be a good option. The object on the other side is actually a bioptic telescope, which can be used for driving. So bioptic telescope driving, there are a lot of, every state has its own laws that govern this. There's a really good website called biopticdrivingusa.com. I still tell my patients to go to their local DMV if they're planning on moving somewhere, just so that we can check out the different requirements. For the state of Tennessee, best corrected acuity in the carrier lens, meaning just best corrected glasses, has to be at least 2200. The telescope correction, so when they're in the telescope, they got to be able to see 20/60 or better. Maximum 4 times telescope. So every state will have a different requirement for what's the maximum magnification they can use in the telescope. And also for Tennessee, less than 5 degrees of central visual field affected and full 150 degrees peripheral field. So again, that's why we run those like binocular ESTERMAN or kinetic field testing. So remember, the central field loss does not always correlate to peripheral field. So I like to check both. So a little bit bioptic driving. Some of you might consider this a little controversial because you're thinking, well, how do my low vision patients drive? So here's a picture of my bioptic. So most of these are mounted directly into the glass. So you can see here on the bottom, that's what we call the carrier, and that basically houses the patient's best corrected distance vision. And then the telescope here, there's different types. There's Galilean, Keplerian, there's adjustable or fixed telescopes. We also have ones that are half semi-automatic, and so there's a little computer that will kind of determine where to focus. But kind of here's kind of a schematic. So if you're driving on the road, and let's say you have retinitis pigmentosa, which is probably the one on the other side here, you might have really good central acuity. So I told you early on, I had a patient who's 20/25 and has RP. They have 5 degrees of field. This here already is much more than 5 degrees of field. Versus you have the blurriness in the center, but you have that periphery that's intact. So the whole point of the telescope, and they have a lot of research on this, is most experienced telescope drivers, they actually spend very little time in that telescope. The telescope's positioned, you might notice it's tilting up a little bit here, because the telescope usually tilts up, it's out of the way, and the patient uses their peripheral field. Remember, central field is only 5 degrees, right? So you have, I don't know, 180, let's say 150 at least degrees of field that you use for driving. And anytime you need to spot something, whether it is a street sign or a traffic light, the patient will dip their head, line up themselves in the telescope, and identify the object and come out of it again. Remember, the telescope will magnify, and all of a sudden they will lose a lot of visual field, and then they have to come out of it. So there's a perceptual change when they jump in and out of the telescope, which is why it actually requires a considerable amount of training to teach our patients how to use a bioptic telescope to drive properly. And then in the grand scheme of things, after they finish a rehab program, they still have to do it behind the wheel and also go through traditional Department Motor Vehicles driving assessment tests. All right, so we're nearing the end here. Advances in technology. So what's cool, what's new? So as you probably remembered from my slides previous ago, we have wearables now. So that's probably what's new. These are some of the wearables. So yes, they have the OCR features, just like a traditional CCTV. Here, from top to bottom, we have an ORCAM. An ORCAM, if some of you have not seen this, it's a small device. It's usually, it's about 3 inches or so. It's got a magnetic clip. It clips right onto a pair of glasses. And it recognizes finger motion. So you kind of touch, and then it shoots a picture. You'll hear the camera go off, and it'll just start reading text at the point of your finger. It's quite impressive. We've also had the chance to play around with it. It will identify street signs, so you just kind of point and it'll read the street sign. It could be like 10, 15 feet away. So pretty interesting stuff. New Eyes, which you can see here in the middle. New Eyes is a full encasing. It's almost like a virtual reality headset. It's a digital magnifier. So you can think it's like a CCTV, except you're like encased in it. Now, and C-Boost, which you see on the bottom there, is it's the same thing except it's monocular, so it's kind of flipped in and it's got that digital magnifier. So big advantage is, yes, these devices can provide far more magnification than a traditional device. The cons, I would say, is, remember I said, the more magnification, the more sensitivity to motion. So I have had some of my patients put these devices on and they're just wobbly. We have to sit them on a chair because they might get so disoriented that it makes them sick to their stomach, because it's like being in those giant IMAX theaters where the whole thing's moving around. It's just too much for them. Again, this might not be appropriate for patients with large scotomas or acuities that are worse than 2400. But these are just a few different devices. There's tons in the market, and there continues to be more released every year. Okay, so the last section is behavioral environmental management. So eccentric view training, just to kind of give you an example of what we do for low vision training. And you see I have a clock here, and the clock, there's a big black dot in the center. I tell the patient there's a dot in the center and there's a traditional clock. And I tell them to look where they think the center is. Remember, some of them have damage phobias, or I sometimes put their finger there. And they look at the clock and they'll tell me, you know, Dr. Ho, number 12 is gone, but number 3 looks really good. And I said, okay, that is your clear window. So then we start to play around and get them to see if we can get them to actively move that clear window around. So I said, okay, so the 3 is clear. Now I want you to make the 12 clear. And they're going to realize they have to look. Sometimes they'll be like, okay, I have to look up a little higher than the actual space, and then they'll get the 12 clear. So they'll learn how to move that clear window more efficiently. So that's also why I train the saccades and the pursuits along with it. Visual field awareness. Yeah, so if you have like a hemifield loss, like we do in a lot of my stroke patients, or we have significant field loss from sometimes a retinal detachment, there's different techniques that we use to train. Ocular motor training. One of the big problems I see is patients have difficulty isolating their eye versus head movement. So when they first have field loss, you'll see these patients kind of swing their head side to side, and they don't realize when to appropriately use their eye movements, which are much faster than head movement. And sometimes it's a combination of both. And then environmental modifications, still stress, you know, reducing clutter, using high contrast colors, tactile aids. So there's little bumper stickers that you can buy and stick on different kitchen devices so that you have a reference on how to use these kitchen devices, even if you can't see actual dots. And so that you have a big button telephone here, for an example. So in summary, low vision tools, I talked about filters, magnification, environmental modifications. Some low vision devices require further training, and I really feel low vision can benefit those with vision loss. And this can be far less than just legally blind. You know, some of my best low vision patients, I think their best corrected is like 20/80, 2100. And that's when we can make a huge change and improve the quality of their life. Because it's very hard to improve quality of life if the patient is truly counting fingers. So I do not work in isolation. We have a huge collaboration team. Like I said, we get a lot of referrals from ophthalmologists, retina specialists. Also, I work with occupational physical therapists. Some of them are trained in O&M, orientation and mobility services, vocational rehab, Tennessee School for the Blind. I do network with also some local low vision support groups. Here locally, we do National Federation for the Blind or Fighting for Blindness. Low vision is a really isolating condition. I find my patients are, depression is at a much higher rate, and they're just more isolated. They don't like to connect with people. In comparison, I have lots of stroke patients, and they like to tell everyone about it. So just something to think about. And assistive technology centers. So some of my patients, if they need one of those digital devices, then I send them to an assistive technology center where they're very well rehearsed. They can do OCR. They have all types of adaptability equipment that they can do for my patient. Also network with low vision vendors, and so we can always keep up with new products rolling up in the market. Some of resources here, practical tips, and these are great websites for your patients. Visionaware.com has a lot of how to, you know, maximize your kitchen and little like tidbits for day-to-day life. Hadley School for the Blind has a lot of how to configure your program, your windows, your phone for low vision accessibility. Telescope driving, like I said, BiopticDrivingUSA.com. We have a National Federation for the Blind. Blind Life on YouTube. That was all the pictures from the wearables. This is a gentleman. He gets he likes to go and just evaluate all those, and he just kind of gives his honest remark, but you can see all the cool different wearable devices out there. So other than that, thank you.
Dr. Ho, we have a couple questions.
Okay, yeah.
So one is there a driver's school locally, and what is the time frame to train and rough cost to the patient?
Okay. So driving school. So I mentioned, I'm guessing this is in reference to the BIOPTIC driving. So in the state of Tennessee, if we're talking about brand new drivers, someone who's never had a license before, they have to be in possession of the telescope for 90 days before they can even get their permit. Okay. Local driving schools. I work with one particular local driving school in Nashville. I work with the Brentwood Driving School, but you know, in other places that might be different. I also work with three what we call CDRS. That's a Certified Driving Rehab Specialist. These are occupational therapists whose specialty is to do behind the wheel. So they not only do low vision, but they'll also do like stroke and neuro rehab patients and train them behind the wheel. So an average, I think the second part of the question was, how much does it cost? It really depends on the product. So most telescopes, I would say, would be within a $1,000 to $2,000 range, depending on option. That's also why we work with vocational rehab, because they'll cover a lot of these services, especially if it can allow a patient to independently go to and from their work. And sometimes I've had patients do grants. There's always some different grants around to fund these sources. And how long does this take? So most of my patients, I would say, we do a really rigorous bioptic telescope training in my office. So we teach the patient how to get in and out of the telescope. We have them on a balance board sometimes. They're like hitting a ball, they're getting in and out of the telescope, they have to be reading things, and basically it becomes automatic and it's like natural as breathing. So we train the patient how to use the telescope efficient. That's considered vision rehabilitation training. And then if the patient gets the permit, then they have to do behind the wheel training. So that really depends on how long patients take to get through that. And then they can go through traditional DMV, Department of Motor Vehicles, to go for their test and then get their licensure. So the quickest I've seen someone do it, you know, highly motivated individuals, I would say is probably about 3 to 4 months.
Thank you. And then one more last question. Are there any low vision aid apps that you recommend?
Yeah, there are a lot of low vision aid apps. A couple I like to recommend. One is called TapTapSee, and another one would be Visor. Visor almost works like a digital magnifier. Of course, the optics will not be as good as, you know, a dedicated device, but some of these, and you can work on Apple. And then there's also a really interesting one that's called Be My Eyes, which is actually a social network. So if you have people who are visually impaired, they log onto this device, and let's say they're going shopping and they're like, I can't tell the difference, I'm looking for a particular brand of, I don't know, canned tomatoes. And they turn on the device, and if you log in, you agree to help them, they'll just kind of hold their device up and scan, and you can direct them to which product they're looking for. So it's a social network for visually impaired individuals, and visual individuals to kind of help each other out.
Oh, someone asked if you could type the names of the apps that you're discussing.
Okay, let's see. Where do I type this? Let me see.
In the chat section, if you see the chat at the very bottom next to share screen.
Let's see. Oh, I have to type it. So tap, be my eye. Did that go through?
Let's see. Just I don't see it. If you'll go to the chat, just go to the chat box maybe and type it to.
I have a Q and answer here. TapTapSee. Let's see. I have an answer.
Oh, okay. So it just came through. Okay.
Oh yes, you can view it under the answered questions. I see. You put it there.
There
So
you got it. Yeah, it's under Q&A.
you would go to Q&A and then answered questions, and that's where it is.
There you go. Thank you.
I guess I can do that too. Hold on. There. Okay. Are there any other questions? Let's see here. There's a question.
Let's see.
Juliet?
Looks like I think that's it.
There's a raised hand here. I'm not sure. How do I? Julianne, can you type your question out?
Sometimes people accidentally hit that, so they may or may not actually have a question.
Yeah, because there's another raise. Now there's two. Okay.
It's kind of easy to do that on accident, perhaps.
Oh, there is one other. Is there other financial resources for blind instruments?
I look at federal grants, and that's why I work with like these different centers. So our assistive device center will probably be more in the know. They honestly, through the years, I just kind of see them come and go. And so I don't actively look for them. I've had also some of my patients kind of raise them through their church and raise them personally. But those are probably my big ones would be vocational rehab and some of these federal grants. And some of these large Lions Club, I do have some patients who've gone through their local Lions Club or various charities to raise funds for their low vision devices.
I think that gets it all the questions answered. Thank you so much, Dr.
Great. Well, like I said, if you need anything, my email's up or was up, jamie.ho@hovisiongroup.com. Feel free to drop me a line. Okay.